Hi, my name is Anne. We're very excited to have you join today's Telehealth Secrets webinar. We're going to be talking about LA County case study on deploying telehealth to 1.2 million. Before we get started, I just have a few quick housekeeping items to go over. So this session will be recorded and you'll receive access to the recording and the slides following today's webinar. If you check out your handout section, you should be able to download a copy of the slides right now. Also, there is a chat box for you to send in your questions anytime during the webinar, and we do encourage you to send them in as you think of them. We'll do our best to get to answer all of them during the Q&A session. And finally, we have lots of great past on-demand webinars that you can check out at VSee.com/secrets. Stuff about patient engagement strategies for the digital age, marketing telehealth to your patients, and just lots of great resources. So recommend that you check those out. So without further ado, I will turn the time over to our host, VSee CEO, Dr. Milton Chen.
Thank you so much, Anne. Welcome to our Telehealth Secrets webinar series. So I'm Milton, I'm the CEO of VSee. So we're the telehealth company that's on the NASA space station. We're excited that working with NASA to bring the astronaut to the moon, return to the moon mission. But today, I'm super excited to welcome our guest from LA County Department of Mental Health, the largest county in the US with over 10 million residents. And especially, I'm super excited to welcome Dr. Marc Heiser, who's a telehealth medical director and award-winning board-certified psychiatrist and the UCLA clinical faculty. We also have their telehealth program manager, Racheal Burgess, who has deployed multiple systems and programs for LA County system-wide. Before we start, I just want to maybe share some fun facts about both our speakers. Something you might not know about Dr. Heiser is that he has a deep interest in transcranial magnetic stimulation, the TMS. On top of that, he's always looking out for the best tacos in the area. Any tips if people need to find something in LA or?
You can send me an email.
Great. And something for you might not able to read from the former professional biographer, Racheal, is she has run LA marathon twice without training, which for me as a casual juggler, that is insane. Like, how did you do it?
Yeah, it was pretty insane. But I finished.
Oh, that is like, you are a superwoman. Yeah, that's like awesome. How about then I'll just turn the floor over to our guests and let them share their thoughts, and then we open up to the audience for questions.
Okay, I'm just sharing my screen now. And let me know, I'm putting it in presenter mode here. When you can see it. It's working?
Yeah, we can see it, Marc.
Great. So my name is Marc Heiser, and I'm a psychiatrist with the Department of Mental Health, where I do a number of things, but one of the main things I do has been running the telehealth program for our department. And I've worked very closely with Racheal Burgess, who has been really key in rolling this out to all of our providers during COVID. So we're going to talk to you a little bit about our experience with it. Just as background, as Milton said, our county is huge. It's a population of over 10 million people, and I think it covers like 4,000 square miles or something. It's the whole department is the largest mental health system in the country, and we have over 80 directly operated programs. Those are ones that the county operates itself. And we see in those programs about 40,000 individual clients a month. And then a lot of our work is done through contract providers as well. So there's over 700 contract providers. We have a very diverse population in LA County, both in terms of race and ethnicity, and also geographically. We have, very dense cities as well as rural areas up in the northern part of our counties, and we've split it up, and it's split up into 8 different service areas, and going all the way up from the Antelope Valley and some of the mountain areas up north to south in Long Beach, and then even including Catalina Island, where it's not easy to find providers out there. So I have to admit, I was in charge of the telehealth program before COVID, and it was really small. We had a few dedicated psychiatrists providing remote services to our directly operated clinics, who are basically short-staffed. So certain areas in our county, like Antelope Valley in particular, it's because they're kind of far out, or have trouble recruiting psychiatrists, and so we would have psychiatrists located more centrally, like in particular at Harbor, near Harbor UCLA in South LA. And those doctors would provide remote consultation and medication management to clinics wherever it was needed throughout the county. And the clients in those days would have to actually come in physically to the clinic and then be put in front of a sort of a kiosk. It was a Cisco type monitor, and we would do the appointments remotely that way. We also were providing some so-called integrated care in behavioral health, in primary care clinics throughout the county as well that way, so as part of a consultation program. But it was tiny and not much teleworking. It was kind of just starting. And then COVID hit, and we had to really, as everybody did, rapidly pivot to providing remote care. And of course, our goals were really to maintain client services, checking in on health, mental health as well, and ensuring people had housing and food security during the early days of the pandemic. But all of our services have shifted significantly to remote work. That includes case management, peer support groups, and community health workers, therapists, nurses, pharmacists, clinical pharmacists, and then mental health psychiatrists providing medication support. So right now, pretty much everything we do can be done remotely, with the exception, of course, of field services, field-based services. But even some of that support can be done remotely. So we've really done a lot with that. And it's been, in my opinion, an opportunity to expand our care and improve access to care in general. So, for example, one of the things we were able to do during the pandemic was start to provide support, psychiatric support for people who are residing in shelters. So our county had to set up, I don't even know the number, but emergency shelters and isolation and quarantine sites throughout the county. And many of the people that were residing in those environments had mental health issues or substance use issues. And we were able to have some people, clinicians in the field there, and have remote psychiatric consultations in those sites to help people who were struggling with that situation. So that some of that's still going on, although it's definitely scaled back. The emergency shelters, for the most part, have been closed or shifted to more permanent sites. And then the other thing that's been important and actually kind of spurred, I think a very important process for our county was to try to redistribute our resources more equitably throughout the county, meaning, as I mentioned before, certain regions in the county have a hard time recruiting psychiatrists, and those clinics would have long wait lists, high turnover, and it was quite difficult for those clinics. But the telehealth change has allowed us to take psychiatry resources and kind of shift them around so that we can cover those clinics remotely. So I do some of that work myself now in the Antelope Valley, seeing clients there a couple times a week. The same idea can be applied in terms of cultural backgrounds or language backgrounds. If we have certain Spanish-speaking psychiatrists, they can, or other languages, they can be, providing care remotely and not just based on where they're able to commute to. So I think that's been an important process that we started to do and that will continue. So really, it's an idea of shifting the idea that a psychiatrist belongs to a clinic, but to actually the psychiatrist seeing clients throughout our system. I'm sure many of the people here who provide services in terms of health or mental health have seen similar changes in client need. But what we've seen is a significant increase in the need for services since the pandemic. And I think it's a combination of things, but this slide really shows just the count of individual services provided for our directly operated clinics only as a function of different months. And it's broken down into telehealth, meaning with video conferencing, which for us is VSee, telephone, and other, which is in person. And what we can see is that before the COVID-19 safer at home order, which happened, I think in March or April of 2020 for us, the dark blue was tiny. I mean, you can't even see it here because it was just my small program doing it. We had a little bit of phone calls in orange, and then most of our services were in person. And then as soon as the safe at home order hit, shifted initially really to phone, and then started, I'm not sure when we started with VSee, but it was probably around this time. Then obviously several thousand-fold expansion of that. Even though these numbers are still small relative to the phone, they did grow significantly and have been steady since then. The other thing is just if you look at the overall number of services we're providing, it's been higher by several thousand-fold every month. So we're providing more services every month and doing most of it either by phone or video. So that's been a huge change. We'd like it, even though phone predominates, we'd really like it to be the video predominating, but that's hard for a number of reasons that I can discuss. But overall, and I don't have a slide for this, but I've looked at individual clients that are being seen in terms of, at least for medication support, we're seeing thousands of more clients every month, new ones. And we're billing actually much more, millions of dollars more every month. So in that sense, since we've shifted to remote work, and I can tell you, my experience with it, providing this care, is that a lot of times it's really difficult for our clients to come in physically. And so being able to provide services over the phone, whether it's remote computer, video or just audio, is a huge deal. And there are many cases where I've sent a VSee invite and called the client up for their scheduled appointment, and they would have missed it otherwise if I hadn't called them. They weren't either aware of it, or they couldn't make it in that day. But because it's so easy to do over the phone or video over the phone now, they have the appointment, and it happens at least once or twice a day for me when I'm providing this service. So I think having that flexibility has been huge, and really the main reason why we have had this increase. I'm not really going to go into this slide in detail, but this compares phone versus tele, meaning video conferencing, for our directly operated clinics. In blue is the tele video conferencing, and with the so-called legal entities, which are contract providers. The contract providers are smaller agencies. There's a few large ones, but for the most part, they're fairly small. And they were able to kind of implement things a little more quickly than us. For us, it's like, churning an aircraft carrier around because we have such a huge system. So they've been able to provide more stuff, more services using the video than we have. We're still mostly on the phone. But even for us, this slide shows actual VSee visits for our directly operated clinics. So we did start in April, and we've just grown, up to, from nothing up to 9,000, visits a month. Now it's back down a bit as we've, this is the time when things were kind of opening up more, and we have had more in-person visits, but we've done a lot to get people on our video calls. Challenges for our clients. So many of our clients either don't have smartphones or enough data to support audiovisual conferencing. That's one issue. They may not have enough minutes to use for telephone services even. That doesn't happen as much. In fact, most of our clients do have smartphones. They may just not be comfortable with using the video conference. In fact, I was on on a call with somebody this morning who just said they just didn't want to try to use it and didn't know how. And then the other issue that comes up sometimes is that some individuals may not have housing, or they may not have space, private space where they reside, and so that's an issue that we have to think about for our clients. Now, as I mentioned before, we're doing, in my opinion, too much on the phone and want to do more video. And I don't have to tell anybody here, but there have been a number of studies for psychiatry, at least, that showing that really outcomes and satisfaction with video conferencing is pretty much equivalent to in-person care, and superior to just telephone visits alone. So we've done a number of things, and Racheal has really led the way with this, to try to increase video conferencing in our system. And that main thing was getting people trained to use VSee and to feel comfortable with it. A lot of I'm going to speak about the psychiatrists. A lot of our psychiatrists may be older and you know, kind of set in their ways. Nothing wrong with that, but asking them to do a whole new thing, a whole new workflow can be challenging. So training people twice a week is one thing that we've done. And then we also worked with some of our staff and community health workers to train what we call VSee champions, to help clients and staff with using VSee, to make sure they're comfortable with it before having appointments. I think that was a very important thing. So each clinic has at least one VSee champion who we can go to for help with this. Now, this may come as a surprise, but one thing that's been challenging for us as a system is implementing a workflow in client for each clinic to get clients online. So every one of our clinics, in some ways, is its own kingdom and has their own, you know, workflows, their own managers, and their own staff. And so, because again we have a very large system, it actually was not easy to get everybody doing something similar, and we're still working at that. So the idea here is to have somebody, you know, ahead of time calling clients, reminding them of their appointment, telling them about VSee, walking them through it, testing it out with them to make sure it works, so that when it comes time for their appointment, they log on without, you know, the providers like me having to do anything. Now, I'll tell you from my experience, when I do have to do it myself, which is pretty frequent, it's super easy because you're just sending, you know, typing in their phone number, sending them a text, and then asking them to follow the link. So for me, it's not an issue to do that. But, you know, for some people, you know, it takes some of the time away from the appointment. And ideally, you'd be logging on and they would be right there already. That's how it really should be. So we're not quite there yet. Every once in a while, we do get that. But sometimes it takes some, you know, reminder call and all that. The other thing we've done is reviewing the use of VSee at these so-called apex meetings, which are where we have reviews of quality measures and things like, you know, percentage service, and sort of holding clinics accountable for using this, because again, this is a quality issue, a quality of care issue for us, and so we've been going through that when there are these more general meetings. We were able to apply for federal funding, and actually did receive that, for getting more telehealth equipment into our clinics, and then we are having every 6 months a quality improvement review of the data in terms of use, and we'll make adjustments. So we're really pushing this. And just an example of how it can work, I looked at clinics that have an established workflow for getting clients onto VSee and compared how many telehealth, meaning video or VSee appointments they have compared to clinics. So that's about 30%. So that gets us up to where those smaller programs, the legal entities, are compared to clinics that don't have a workflow. It's still in the 10% range. So the workflows for getting clients online are critical, and we need to keep improving that to provide the best care for people. In terms of where we're going, one big thing for us is we have obviously an electronic medical record system, and it's separate from VSee right now, and we've kind of put it on the back burner, but ideally those should be integrated in a way that clients are scheduled in one system and it shows up in the other, so we don't have to kind of go back and forth. And then I've mentioned kind of leveraging the cultural capacity of our providers to match that of our clients in terms of the cultures of our clients, because we can do that remotely rather than somebody from another region having to travel to get a provider that speaks the same language. We are implementing customer satisfaction surveys in order to kind of tell us how we're doing, how clients like this. And then finally, one thing I want to do is explore more funding for smartphones and data for our clients, because that can be an issue still. So I think that's all I have, and I'm happy to take questions.
Dr. Heiser, thank you so much for that really insightful presentation. And I guess I just want to maybe applaud you and Racheal for leading such a massive program and the impact on society and so on. And as we're getting some queue for some questions, I think Anne will do a quick technology poll. And maybe for the audience member, please feel free to click on any of these, but we definitely want to understand your perspective on telehealth.
Okay. Sorry, we'll give it about 30 more seconds.
Okay.
Yeah. Go ahead, Milton.
Yeah. I guess, Dr. Heiser, for your, I guess one of the thing I was really curious about, I think the patient population you serve are, like really, really challenging. They come from very diverse set of backgrounds, situations. Like, what are some of the maybe extreme scenarios or type of patient you have to get them onto telehealth?
I mean, well, one issue that's been talked about even in the literature is like thinking about who's appropriate for telehealth. Are there mental health conditions that it wouldn't work well for, and the no contraindication to telehealth, but certain people that have, say, psychotic disorders, which can include, paranoia or even delusions related to technology, and we certainly have a large number of clients that have those issues and just wouldn't, be comfortable doing a video chat, and also may not have the cognitive capacity to kind of do it. For those clients, however, we have them come into the clinic, and Racheal has worked on establishing what we call kiosks in clinics, which are, basically an office room, a patient room that has a video monitor where they can have the interaction within the safety of a clinic at least, and it's set up for them, and they could have another caregiver with them or support if that makes it easier. Same thing with people that have, say, developmental delays or intellectual disabilities who need more assistance. That can be challenging, and so that we have a lot of clients like that are affiliated with regional center, but often they have caregivers that can assist. So I think it works pretty well in terms of different conditions.
Got it. Yeah, this is like it's just hard to imagine the diverse set of these, the type of the patient you have to support. I guess I have a question for Racheal is like, so as you're building up, scaling this program, like, what is the effort like on your end? Are you talking about like couple of weeks or couple of months? I know you work insane. You work 7 days a week. I talk with you a minute. Like this, like for example, if you were to advise, let's another county government, like how many staff, how much time does it really take to get this program off the ground?
Wow. Well, when we, the team, we had a really great team and good management. And because it was right in the middle of COVID and it was an emergency, we were able to implement, and we were up within a couple months. Within a few months, we were up. Within a couple months, actually, we were up. And we started off with a pilot with just psychiatrists, getting them onboarded because that was the fastest. But basically, we had management actively involved. We had technology, the tech folks, security people, everybody pretty much made themselves available. So it was a all hands on deck. And because it was an all hands on deck and it was an emergency, literally, we may be talking on a weekend or, I may call Marc at, 6 o'clock or 8 in the morning or 7 in the morning because it was an emergency. So we kind of all did what we needed to do in order to get it up. And because of that, we were able to procure and do all the things that we needed to do, very, very quickly. Ideally, a project like this, and I've worked on many, doesn't get rolled out that quickly, but we were able to really all come together and everyone make themselves available and make this a priority in order to roll it out so quickly. But we had a team. I don't know, Marc, how many people do we have? Oh my gosh, it was probably, at least 10, 12, right? I mean, at least, because we had support folks, we had security, we had management, easy, 10, 12 people just constantly doing their piece. Everyone had a piece, so.
Yeah.
That's a pretty big team in Kansas too. We have a question from the audience, Brandon. So he's asking, so what are the intake and paperwork processes you face? Are you able to do all the paperwork virtually, or do you have them in person with each other, maybe existing patient? Well, I guess, how do you handle that?
Do you want me to take it, Marc, or you got it?
You can go for it.
Oh, okay, so with the paperwork, and Mark, help me out because I know you actually do it. So a lot of our paperwork is still done via the process we normally did through our EHR.
Okay.
There have been a request for us to allow some of those documents to be in VSee, but we're still working out that. We'll have to work with Marc, Dr. Heiser, and others to get an approval for that. But right now, a lot of that documentation is still done via our EHR, our electronic health records. And Marc, please add to that because you would know better than I.
Yeah, I mean, it is unfortunately, that's a work in progress for us, but clients do often have to come in to sign some of the paperwork in terms of, financial screening and those issues. Consents we're doing, at least for medications right now, we're doing kind of verbal consent and documenting that. That we'd like to change and I think work with VSee to implement a process for that.
Yeah, and we do have a change request right now that is requesting for that very thing. So we've been working with the VSee tech team to talk to them about what would be required in order for people to be able to, sign, and then we'll have to go through the normal security and letting management see what it looks like, etc. But it is on our roadmap.
Got it. Okay. So a question from audience Letitia. She's asking, so she's a therapist working on, like children. So she's asking, do you have data that break into like the different age group of the population? How young do you go into for the patient you guys serve?
Well, we serve everybody in terms of age range. I haven't looked at our data on children. Most of the child and adolescent work we do is actually contracted out. So, so for us, I'm not as sure. That said, I'm a child psychiatrist and do some contract agency work, and it is mostly online.
Marc, in that case, do you normally have parents join the session? What is this like a protocol? Because I think that dealing with young children can be very difficult in the telehealth experience.
Yeah, the little ones, it's hard because so much of it is seeing how they are in behaving in the office. But it works pretty well. The parents, are always a part of it. The one issue that we do have is, privacy there. Like if it's an adolescent, making sure they have privacy when they do talk to us. But it seems to be workable for the most part.
Yeah, we know we have one of our children, as we look at the utilization, one of our children providers, they do very, very well. And we've worked with VSee to implement a process within VSee where you can tell if it's dependent. So if a parent has multiple children and they're both being seen by DMH, then the parent's able to actually look and see the information for both kids. And we've worked that out so that can happen. So, but a lot of the services are being provided virtually.
Got it. Okay. So I have a question for Rafa in the audience. So is there any regulations when you have patients from different states that, let's say, you if the therapist, let's say, is not licensed yet? Again, you guys, do you ever serve patients who maybe in they don't live in LA, they just were visiting or temporary, it doesn't matter, or?
If they're visiting LA, we can see them, but if they're from out of state, it would be, kind of an insurance issue. We cannot see people out of state.
Okay.
If they're even if they're from LA, they go out of state, we can't see them. They have to be they're supposed to be in the county if we're providing services for them. So I have had, the situations where people move or they just even travel, and we have to kind of prepare for that ahead of time because we can't see them if they're out of state. And so that's for our system. And in general, laws about telehealth I'm not sure if you want me to talk about that, but they're different, between the medical side and the therapy side. So at least for the medical part, you have to have a license in whatever state you're providing in for the most part. There are some exceptions to that, especially during the pandemic. There were some emergency exceptions, but it's a state by state.
Got it. That makes sense in there. So Stephanie from the audience is asking, so in terms of when you think about HIPAA issues in there, what, HIPAA is this, in some sense, is very rigorous and sometimes it's hand waving things. What was you guys' approach to making sure everything is HIPAA compliant and so on? I guess the things that beyond maybe just the platform.
I'll tell you my take on that, and Racheal can chime in, but we have a very kind of high standard in terms of security, information technology security, and so that was a big deal for us in choosing our platform, the VSee. We had other possible things coming up and people wanting to use this and that, and so we've been pretty rigorous in terms of VSee being HIPAA compliant and that. I don't know, Racheal, what your
absolutely, Mark. I wouldn't have said it different. I mean, we have a very good security team, our IT folks, and they're, we are very, very disciplined about making sure things are HIPAA compliant. So I 100% agree with what Mark said. Yeah, just ditto that.
Yeah, I mean, the other thing is, so the other side of it, I feel like, is sort of, like there are times when I contact a client and they're like, out somewhere, and but they still want to have the appointment. So I think that it's sort of balancing the need for continued care with the risk of them losing their privacy. And I think that they have to make that decision to some extent too.
Got it. There. In terms of the provider and in this, I know Mark, you mentioned is sometimes these providers, they have been practicing for so many years. When they transition technology, it's difficult in this. Do you have a rule of thumb, for example, like how many hours, how much time does it take a provider in training until they feel like really comfortable, doing telehealth?
Well, there's a lot of variability there. I would just say, if they had a half a day training, that should be adequate.
Okay.
It's not that difficult, especially the VSee software is super easy. Our EMR is a whole nother story, but the actual video conferencing app, this is very easy.
Got it. How about in terms of for each visit, each appointment is for example, is there do you have rule of thumb, let's say appointment is, let's say 11 a.m. in the, how much time does a provider need to budget to, get on top of technology? Or is that pretty, like seamless? Like, yeah.
Well, usually it's seamless. Most of the time, it may take 5 minutes. And then there are the exceptions where, you know, something just doesn't work. Connections poor. So I would say most of the time it shouldn't take more than 5 minutes to get connected.
And I'd like to add to that, not about the time, but just about what Marc mentioned earlier. Whereas when we have those workflows in place, it's just so much smoother, because one of the things about the time is that whether the client knows how to log in or whether the clinician or psychiatrist has to help them. So I think those workflows that we've implemented at a lot of the sites, when those things are done ahead of time, then it's easier for the doctors and the clinicians to be able to kind of just join the call and it'd be seamless, right? Because the client already kind of knows, unless they of course run into some, you know, technical difficulty. But ultimately that workflow that we have is really key, which is kind of what Marc said, for a more successful number of calls that, you know, that are, you know, seamless. It's easy.
Got it. Okay. So I have a question from the audience, Johanna, asking, so do you provide any like these or holistic, you know, doctor services, you know, things like health and life coaches and those type of things?
Well, not, I mean, I think that, you know, we don't have life coaches. We do have, you know, peer support groups and the position I think it's called it community health workers, who are people that really work individually with clients and do some groups on like more life skills, or, you know, helping them navigate you know, issues, you know, for example, getting a phone, access to technology. So, but that, it's not, I guess that's less, I consider that holistic, but it's more, you know, client centered, or less medical.
Marc, I'm just so sorry. I had a network glitch. I think I temporarily. Can you hear me back?
Yeah, we can hear you now.
Okay, I'm so sorry, but I think I have this AT&T. They send me multiple. So sometimes glitches, just my bad luck. I guess we have a question from Craig. So he's asking, is your group and at the county level doing anything to sort of increasing like the number of folks who have sort of broadband access beyond like a smartphone? Is there any initiative just helping, you know, your patient population have, you know, better access to the network?
Well, I think that is that's like one of my future directions. I think really trying to find funding, you know, to improve that. For a while, the county was providing internet hotspots and things like that through the county libraries. And so, and then there were some of the broadband providers through the school system providing Wi-Fi access. But we had somebody that was starting to work on that issue. And they've moved on, but that's one of the things. I mean, I think it's an opportunity for like private sector companies to kind of pitch in, and I mean, I know Facebook is like evil in some ways, but they did a lot of infrastructure work in some other countries, and so why not do some of that here? Not, yeah. So.
Got it. That makes sense. And, I guess Craig also has a follow-up question is, do you have any program in terms of actual libraries, in terms of things, these are digital navigator or other ways to help patient, to source patient or even provide services in a like library setting?
Well, I think an issue with that is privacy. I mean, I think we've thought of having kind of kiosk setups in public things, spaces like libraries, but we haven't implemented that yet, or figured that out. So I think it's a really interesting idea. But it has to be done, very carefully.
Yeah, I think there were a lot of security considerations, and that's one of the reasons why I know we haven't, because like Marc said, we've thought about it, but there are a lot of security considerations for that.
Yeah, that makes sense. Yeah, it is. I think the mental health in public setting is probably maybe not a natural match in there.
I mean, there are like, I'm sure you've heard of these, pharmacies like CVS and that are opening even mental health clinics in some areas. So that's kind of in that direction.
That makes sense.
Not quite a library, but.
Okay. Yeah, we have a question from Erica asking about how do you deal with like a patient no-show or last minute cancellation? Because I guess my hunch, she's probably thinking through, especially given the population you guys serve, probably there's like their socioeconomic challenge, something these no-show might be, how do you, I guess, handle those cases?
Well, so before we were really using telehealth so broadly, our no-show rate was, I don't know, at least 25%, I think probably higher. And no-shows, they still happen all the time, but it's a little easier. And I think, again, my experience has been, using the telehealth has really prevented the no-shows a lot, or been beneficial. And I haven't been able to quantify it yet because we don't have a great no-show system, but there's been so many times where I've called a client up or sent them that text and then call them and say, hey, you have an appointment now, and then we're able to do the appointment. They would have missed it 100% otherwise. So it just gives you flexibility.
Got it. Okay. So one thing that you were mentioning is it was really intriguing, Marc, in your presentation, how you can sort of take these providers, then it would really expand the area based on language, like the culture awareness in this. I guess right now in terms of your program, like how is that, I guess, spread out to other patients? The reason I'm asking is I'm assuming is in these therapy sessions, you actually have a strong relationship, right? Now, how will someone, let's say, know this provider who, let's say, speak a certain language in another location? Do you have a program to, I guess, try to match them up? Do they provide a patient match? Like how does that program run?
Well, right now it's really early phase stages for that, but the idea is, I mean, we learn of our clients' background and language when they come in, for their initial financial screening, and so then after that they could be assigned to a provider that with the appropriate background, and So our system is still kind of stressed in terms of staffing and having enough psychiatrists and clinicians.
Sure.
We haven't been able to have this really flexible system where we have sort of dedicated providers that can be available. But it kind of right now it works on on an individual basis, and we know of certain providers, and they can take on clients remotely based on backgrounds. That's how we've been doing it. But ideally, it would be much more fluid than that, and you could really see clients throughout the county, regardless of where they're located.
Got it. That makes sense. So I have a question from Stephanie asking, do you use a wait list to fill like the no-show opening? And if so, how do you actually manage that wait list process?
So that's a major issue that we're in the process of tackling right now.
Yeah.
Some clinics do have a good system for that, where they will have a standby list, and the client, the provider, if a client no shows, will let the clinic know, and then the other person's ready and can set in. So that's the way I think it works best, is if there's really an active standby list. And I'm communicating a lot with the clinic where I'm working with the staff there, so that we have ways of just texting them, so I can, this person didn't show up, and then they can slot them in.
Got it. Great. Marc, Racheal, really appreciate all your insight in there as we come out the tail end of the hour. As we just have like a couple of rapid fire questions as we're have the audience get your insight. The first rapid fire question is like, what was something that was really surprising to you from your telehealth journey?
Racheal, you want to do that?
Yeah, I'll take it. Actually, I was really surprised. I've been really surprised at how kiosk has kind of taken off, and I was really surprised as well how actually well the staff did with just starting to have those individual sessions. People kind of like really picked up with it. So I, as a project manager, and it kind of everything happened so fast, I was very impressed by how quickly each of the various disciplines just kind of picked up and started doing virtual telehealth. I mean, obviously there were some, struggles along the way with learning the technology and the phones and workflows and stuff, but ideally, I was really shocked how people kind of picked up and just kind of started doing it. What about you? What about you, Marc? What are your thoughts?
Yeah, I mean, my surprise was that I like providing care remotely. I had an idea that I wouldn't, and I had an experience a while ago where I was in sort of a urgent care setting. It was just very busy, and I did some telehealth, and it was not too fun, but it's been great. I think you're able to establish rapport with people, and so it's been good, and it allows me to work from home sometimes too, which is nice.
Got it. Then the final question is, supposedly you can whisper a thought into President Biden's ear, and he'll do whatever you want within the healthcare setting. What would be that idea you want to plan or implement?
Well, I mean, to me, if I had to choose one, you're gonna make me choose one thing.
I'm only
the
most
one thing
important.
would be, really elevating mental health care to the level of regular medical care. It's still, there's still issues with, reimbursement, and it's just not. I don't think it's still there. So that would be my one thing, and then the other thing would be the infrastructure, making it more equitable so that everybody can have access to broadband.
Yeah, and I'd piggyback on top of that by saying, yeah, absolutely, that second piece about access to broadband and just money being available so that clients can get phones and get internet, and they don't have to worry about the costs associated, and that'll just make it more equitable for everyone. So I think that would be my big push for the money. Actually, both things Marc said.
Great. Okay, thank you so much, Racheal. Thank you so much, Marc, for your insight in this. Again, for the audience member, really appreciate you joining us for another telehealth secrets webinar on this. And then we'll be sending out the recording and the slides following the sessions. And also we have a survey to get your insight in this. And we also just gear out for hymns in Orlando. So we definitely would love to see any audience members there in person. And again, so thank you again so much for Dr. Heiser. Thank you so much, Racheal, for your insight. Really, really appreciate it.
You're welcome for having us.
Thank you. Bye-bye.
Bye.